This recorded lecture will be going over Unit 6 in the ATI PN Mental Health Nursing Textbook. This will be going over chapters 29 through 32. Starting with chapter 29, Crisis Management. A crisis is an acute, time-limited, usually lasting 4 to 6 weeks event during which a patient will experience an emotional response that cannot be managed with their normal coping mechanisms. During crisis intervention, it's assumed that the patient was well functioning and mentally healthy. Everybody experiences crises. A crisis is not pathological, but it represents a struggle for equilibrium and adaptation. Crises are also personal in nature. What might be considered a crisis for one person might not be so for one another. During crises, the individual will experience either psychological deterioration or growth. Let's look at some common crises characteristics. The patient will experience a sudden event with little or no time to prepare for it. Their perception of the event will be overwhelming or life-threatening. A loss or decrease in communication with significant others can occur. They will feel a sense of displacement from the familiar, and they will have an actual or perceived loss. Let's look at some types of crises. There's a situational or external crisis. This is often an unanticipated loss or change experienced in everyday, often unanticipated life events. An example would be a divorce or a job change. There is maturational or internal crises. This is achieving new developmental stages, and it can require learning additional coping mechanisms. Examples of this would include getting married or retiring. There are adventitious crises. This would include the occurrence of natural disasters, crimes, or national disasters. So natural disasters, crimes, or national disasters. This would also include people in communities with large-scale psychological trauma that can be caused by natural disasters. Data collection. The nursing history should include the presence of any suicidal or homicidal ideation, the patient's perception of their precipitating events, any cultural or religious needs of the patient, their support system, any present coping skills, any disorganization, any feelings of overwhelm and anxiety, any evidence of inadequate problem solving, and any possible anger or aggression. Some risk factors for crises include the accumulation of unresolved issues, any current life stressors, any concurrent mental and physical issues, any excessive fatigue or pain, and the age and developmental stage of the patient. Protective factors against a crisis includes a support system and prior experience with stress or a crisis. So let's look at the phases of a crisis. In phase 1, the patient will feel escalating anxiety from a threat. It will activate increased defense responses. Phase 2, anxiety continues to escalate as the defense responses will fail. Functioning becomes disorganized. The patient will now resort to trial and error attempts to resolve their anxiety. Phase 3, trial and error methods of resolution have failed. The patient's anxiety is escalating to severe or panic levels. This can lead to flight or withdrawal behavior. And finally, phase 4, the patient experiences overwhelming anxiety. This can lead to anguish and apprehension, feelings of powerlessness and being overwhelmed, dissociative findings such as depersonalization or detachment from reality, depression, confusion, and/or violence against themselves or others. Some nursing care. Crisis intervention is designed to provide rapid assistance for individuals or groups with an urgent need. This care is directed at the resolution of the immediate problem causing the crisis. The initial task of the nurse is to promote a sense of safety for the patient and protect them by monitoring their potential for suicide or homicide. We need to prioritize interventions to address their physical needs first. Initial interventions would include identifying the current problem and directing the interventions for resolution, taking an active, directive role with the patient, encouraging active participation by the patient in planning solutions and goal setting, and helping the patient set realistic, attainable goals. We want to use strategies to decrease anxiety. This would include developing a therapeutic nurse-patient relationship, staying with the patient, listen and observe, make eye contact, ask questions related to the patient's feelings, ask questions related to the event, demonstrate genuineness and caring, communicate clearly and if needed with clear directives, avoid false reassurance and other non-therapeutic responses. Reinforce any teaching about relaxation techniques, and assist the patient in developing an action plan. They should have a short-term action plan. It should be focused on the crisis. It needs to be realistic and manageable. They should include self-assessment by the nurse, as well as a debriefing with staff. Critical incident stress debriefing is a group approach that can be used with a group of people who've been exposed to a crisis situation. Medications. We can administer anti-anxiety or antidepressant medications as prescribed. Psychotherapeutic interventions. In the primary care setting, we can collaborate with the patient to identify any potential problems, instruct them on coping mechanisms, and then assist them with any lifestyle changes. In the secondary care setting, we can collaborate with the patient to identify interventions while still in an acute crisis to promote safety. And in the tertiary care setting, we can collaborate with the patient to provide support during recovery from a severe crisis. This would include outpatient clinics, rehabilitation centers, crisis stabilization centers, short-term residential services, and workshops. Patient education. They need to be aware that there are services in the community that can provide assistance during a crisis, such as crisis stabilization, hotlines, warm lines, mobile and peer crisis services. They also need to be educated to adhere to their plans for any follow-up appointments. Chapter 30, Suicide. Suicide is the intentional act of killing oneself. A client who is suicidal can be ambivalent about death, and interventions can make a difference. A patient contemplating suicide will believe that the act is the end to their problems. They have little concern to the aftermath or the ramifications to the people left behind. Long-term therapy will be needed for survivors. Suicidal ideation will occur when a patient is having thoughts about committing suicide. Patients can have feelings of hopelessness, helplessness, and inner pain. Let's look at some myths regarding suicide. One myth is that people who talk about suicide never commit it. People who are suicidal only want to hurt themselves, not others. There is no way to help someone who really wants to kill themselves. Not true. Asking a patient about suicide will cause that suicidal individual to actually commit the act of suicide. Again, absolutely not true. Ignoring verbal threats of killing oneself or challenging a person to carry out those plans to kill themselves will reduce the individual's use of the behaviors. In fact, it is actually the opposite. It will encourage them to perform those behaviors. And people who talk about suicide are only trying to get attention. Maybe they're trying to get your attention to actually help them stop what they feel so compulsive to do. So take a look at those myths, understand them, and then throw them out the window because they have absolutely no bearing on how we should be caring for this type of patient population. Let's look at some risk factors. While females are more likely to attempt suicide, adolescent, middle, and older adult males are more likely to have actually carried out the act and have died by suicide. Other individuals at increased risk of suicide would include active military personnel and veterans, those who are lesbian, gay, bisexual, or transgender, and people with a comorbid mental illness, such as depressive disorders, substance use disorders, schizophrenia, bipolar disorder, and personality disorders. Let's look at some risk factors specifically for our older adult patients. This would include untreated depression, a loss of employment and finances, feelings of isolation, powerlessness, any prior attempts at suicide, any change in their functional ability, their declining physical health, any alcohol or substance use disorder, and a loss of a loved one. Biological factors that increase the risk of suicide include a family history of suicide, as well as physical disorders such as AIDS, cancer, cardiovascular disease, chronic kidney disease, cirrhosis, dementia, head injury, Huntington's disease, and multiple sclerosis. Psychosocial factors influencing the risk of suicide include a sense of hopelessness, intense emotions, poor interpersonal relationships at home, school, and work, developmental stressors like those experienced by adolescents, and a history of trauma or abuse. Cultural factors influencing suicide. Whites are at the highest risk than any other culture and have the highest incidence of completed suicides. This is then followed by Native Americans, African Americans, Asian Americans, and Hispanic Americans. Environmental factors that increase the risk of suicide include access to lethal methods like firearms, lack of access to adequate mental health care, and unemployment. Protective factors that will reduce the risk of suicide in an individual include feelings of responsibility towards a partner and children, a current pregnancy, religious and cultural beliefs, overall satisfaction with life, presence of an adequate support system, effective coping and problem-solving skills, and access to adequate medical care. Expected findings. We need to monitor these patients very carefully for any verbal and nonverbal clues. It is absolutely essential to ask the patient directly if they are thinking of suicide. It will not give them the idea to commit suicide. Suicidal comments are usually made to someone that the patient will perceive as supportive to them. Comments or signals can be overt, which means direct, or covert, indirect. An example of an overt comment would be, "There is just no reason for me to go on living." An example for a covert comment would be, "Everything is looking pretty grim for me." We need to monitor the patient's suicide plan. We need to ask them if they have a plan, then determine how lethal that plan is. We need to see if they can describe the plan exactly. Do they have access to their intended method? Has their mood changed? A sudden change in mood from sad and depressed to happy and peaceful can indicate a patient's intention to commit suicide. Physical findings would include lacerations, scratches, and scars that would indicate previous attempts at self-harm. Nursing care. Nursing care will consist of primary, secondary, and tertiary interventions. Primary interventions will focus on suicide prevention. This is through the use of community education and screenings to identify at-risk individuals. Secondary interventions will focus on suicide prevention for an individual patient who is having an acute suicidal crisis. Suicide precautions are included in this level of prevention. Tertiary preventions will focus on providing support and assistance to survivors of a patient who have died by suicide. Suicide precautions. This can include MILU therapy within the facility. We need to initiate one-on-one constant supervision around the clock. Always have the patient in your sight and close by. Documentation needs to indicate which staff member is accountable for that patient with specific start and stop times. There is a very increased risk of suicide during staff rotation times. Document the patient's location, mood, any quoted statements, and behavior every 15 minutes or per your facility protocol. Search the patient's belongings with the patient present. Remove all glass, metal silverware, electric cords, vases, belts, shoelace, metal nail files, tweezers, matches, razors, perfume, shampoo, plastic bags, and any other potentially harmful items from the patient's room and their vicinity. Allow the patient to only use plastic eating utensils and count them when brought into and out of the patient's room. Check the environment for any possible hazards, such as windows that are open, any overhead pipes that are easily accessible, non-breakaway shower rods, and non-recessed shower nozzles. Always ensure that the patient's hands are visible, even when they're asleep. Do not assign that patient to a private room, and that door needs to remain open at all times. Ensure that the patient is actually swallowing all their medications. Some patients will try to hoard medication until there's enough built up for a suicide attempt. Restrict visitors from bringing possibly harmful items to the patient. Self-assessment is a very important part of suicide care. The nurse needs to determine how they feel personally about suicide. They need to feel comfortable asking personal questions about suicidal ideation and follow up on the patient's answers. Nurses who work with patients with suicidal ideation can benefit personally by debriefing, sharing, and collaborating with other healthcare professionals. Let's look at some medications that we can use to prevent suicide. This would include antidepressants, such as selective serotonin reuptake inhibitors. Some nursing actions for this medication category include a decreased risk of lethal toxicity compared to other categories of antidepressants. These patients should not stop taking this medication suddenly, and this medication can take 1 to 3 weeks for therapeutic effects for initial response, with up to 2 months for a maximal response. We need to monitor for indications of increased depression and the intents of suicide. We can also treat with sedative hypnotics and anxiolytics or benzodiazepines. Patient education with this type of medication category includes avoiding the use of other CNS depressants, such as alcohol. Caffeine will interfere with the desired effects of the medication, and they should never abruptly discontinue the medication. Mood stabilizers are another category of medications we can use to prevent suicide, and our primary agent would be lithium carbonate. Nursing actions include ensuring that the patient is maintaining an appropriate sodium intake. Patient education includes telling them to take the medication with food or milk to minimize any gastrointestinal effects. We can also use second-generation antipsychotics. These are preferred over first-generation antipsychotics due to their decreased adverse effects. Patient education would include informing them to report any clinical findings of agitation, dizziness, sedation, and sleep disruption to the provider, as the medication may also need to be changed. Therapeutic procedures that we can do to help would include therapeutic communication. When questioning the patient about suicide, always use a follow-up question if the first answer is negative. For example, if the patient says, "I'm feeling completely hopeless," the nurse says, "Are you thinking of suicide?" The patient says, "No, I'm just sad." The nurse says, "I can see you're very sad. Are you thinking about hurting yourself?" The client says, "Well, I've thought about it a lot." Limit the amount of time that an at-risk patient will spend alone, and involve significant others in the treatment plan. ECT can be an effective therapy in decreasing suicidal ideation in patients with a depressive or psychotic disorder. Patient education. We need to assist the patient in developing a support system list. It needs to have specific names, agencies, and telephone numbers that they can call in case of an emergency. Care after discharge includes having the patient agree to a no-suicide contract. This is verbal or written agreement that is made not to harm themselves, but instead means they need to seek help. Now, we need to know that this is not a legally binding contract, and it only should be used according to your facility policy. A new suicide contract can be beneficial, but it should not ever replace other suicide prevention strategies. A no-suicide contract can be used as a tool to develop and maintain trust between the nurse and the patient. A no-suicide contract is discouraged for patients who are in crisis, under the influences of substances, psychotic, very impulsive, and/or very angry or agitated. Chapter 31, Anger Management. Anger is a normal feeling. It's an emotional response to frustration that's perceived by the individual. Anger can be positive if there's truly an unfair or wrong situation that needs to be righted, but this needs to be expressed in a healthy manner. Anger can become negative when it's denied, suppressed, or expressed inappropriately. This is by using aggressive behavior. Denied or suppressed anger can manifest as physical or psychological findings. Anger can be referred to as secondary emotion related to another disorder, such as depression, unresolved grief, anxiety, or unresolved PTSD. Aggression, whether in action or behavior, will result in a verbal or physical attack. Violence is an act that is goal-directed with the intent of harming a specific person or object. Inappropriately expressed anger can become hostility or aggression. A patient who is often angry and aggressive can have underlying feelings of inadequacy, insecurity, guilt, fear, and rejection. Comorbidities for anger management or for anger disorders would include depressive disorders, substance use disorders, bipolar disorders, post-traumatic stress disorder, Alzheimer's disease, personality and psychotic disorders, and individuals who are easily overwhelmed with marginal coping skills. Seclusion and restraints. Seclusion and restraint must be used only according to legal guidelines and should be the intervention of last resort after all other less restrictive options have been tried, as there is a risk of harm to the patient and others. Less restrictive interventions that can be implemented prior to the use of restraints would include verbal interventions, offering a needed medication, decreasing the client's stimulation in the environment, close observation, and one-to-one supervision. Seclusion and restraint do not usually lead to a positive behavior change. Seclusion and restraint can keep individuals safe during a violent outburst, but the use of restraints itself can be dangerous, and it has, on rare occasions, led to the death of patients due to reasons such as suffocation and strangulation. When it is deemed essential to use restraints, remove the patient from seclusion or restraint as soon as the crisis is over and when the patient attempts reconciliation and is no longer aggressive. Some risk factors for anger management include a past history of aggression, poor impulse control, and violence, poor coping skills with a limited support system, any comorbidity that would lead to an act of violence, such as psychotic delusions, command hallucinations, violent angry reactions with cognitive disorders, living in a violent environment, and limit setting by the nurse within a therapeutic milieu. Expected findings with anger include hyperactivity such as pacing and restlessness, hypersensitivity and being easily offended, eye contact that is intense or no eye contact at all, facial expressions like frowning or grimacing, body language such as clenching fists or waving arms, rapid breathing, aggressive postures like leaning forward and appearing tense, verbal clues like loud, rapid talking, yelling, and shouting, and drug or alcohol intoxication. Nursing care. We need to provide an environment that is safe for the patient who is aggressive, as well as for the other patients and staff on the unit. We need to monitor for triggers or preconditions that will escalate the patient's emotions. And we need to perform a self-assessment to have that self-awareness. Steps to handle aggressive behavior. Some steps to handle aggressive and/or escalating mental behavior in a mental health facility would include the following. You need to respond quickly. You need to remain calm and in control. Encourage that patient to express their feelings verbally and use therapeutic communication techniques, such as reflective techniques, silence, and active listening. Give the patient as much personal space as possible. Maintain eye contact and sit or stand at the same level as the patient. Communicate with honesty, sincerity, and a non-aggressive stance. Avoid accusatory or threatening statements. Describe options clearly and offer choices. Reassure the patient that staff members are present to help prevent loss of control. And we need to set limits for the patient. Tell them calmly and directly what they need to do in a particular situation, such as, I need you to stop yelling and walk with me to the day room where we can talk. Encourage the client to use physical activity, such as walking, to de-escalate anger and behaviors. Inform the patient of the consequences of their behavior, such as a loss of privilege. Use pharmacological interventions if the patient does not respond to calm limit setting. Plan for 4 to 6 staff members to be available and in sight of the client. This provides a show of force and can be appropriate. Following an aggressive or violent episode, you need to discuss ways for the patient to maintain their control during the aggression cycle. Check the milieu and identify any potential and actual stressors that might have contributed to their behavior. Encourage the patient to talk about the incident, what triggered and escalated their aggression from their perspective. Document the entire incident and include the following: any behaviors leading up to, as well as those observed throughout the critical incident, and any nursing interventions implemented, as well as the patient's response. Medications that we can use for anger management disorders include olanzapine and ziprasidone. Olanzapine and ziprasidone are used to control aggressive and impulse behaviors. These are used more commonly than haloperidol because of the severity of the adverse effects of haloperidol. Haloperidol, also known as Haldol, is an antipsychotic agent that can be used to control aggressive and impulsive behavior. Nursing actions would include keeping the patient hydrated, checking vital signs, and testing for muscle rigidity due to the risk of neuroleptic malignant syndrome. Other medications that can be used to prevent violent behavior by treating the underlying disorder. These would include antidepressants, mood stabilizers, and sedative hypnotic medications. Patient education includes returning for follow-up care and attending a support group, and care after discharge would include managing their medications and developing problem-solving skills. Chapter 32, Family and Community Violence. Violence from one person towards another is a social act involving a serious abuse of power. Usually, a relatively stronger person will control or injure another, typically the least powerful person accessible to the perpetrator. This will include an act of violence that a partner commits against the other partner, adult abuse by a non-spouse or non-partner, a parent against a child, or a child against a parent. Let's look at the cycle of violence. Spouse or partner violence will typically follow a very predictable cycle. We're going to begin with the tension building phase. In this phase, the perpetrator has minor episodes of anger and can be verbally abusive and responsible for minor physical violence, like pushing or shoving. Tension will continue to grow, and both partners will try to reduce it. The perpetrator might turn to substances, and the victim will dismiss the significance of the violence. The vulnerable person is tense during this stage and will accept blame for what is happening. Then we enter the acute battering phase. The tension becomes too much and serious abuse now takes place. The victim can provoke the perpetrator to reduce the unbearable tension. The vulnerable person can try to cover up the injury or try to get help. This stage is typically the most violent and also the shortest stage. Then we enter the honeymoon phase. In this phase, the situation is diffused for a while after the violent episode. The perpetrator will become loving, promise to change, and say that they're sorry for their behavior. The vulnerable person wants to believe that and will hope for a change. Eventually, the cycle will begin again. Periods of escalation and de-escalation will usually continue with shorter and shorter periods of time between the two without intervention. Emotions for the perpetrator and vulnerable person will increase in intensity. Repeated episodes of violence will lead to feelings of powerlessness. Let's look at some types of violence. A nurse needs to be able to prepare to deal with various types of violence, as well as the mental health consequences. Violence can be directed towards a family member, stranger, or acquaintance, or it can come from a human-made mass casualty incident, such as a terrorist attack. There are natural disasters like hurricanes and earthquakes that can cause mental health effects comparable to those caused by human-made violence. Violence against a person with a mental illness is more likely to occur when different factors, such as poverty, a transient lifestyle, or substance use disorder, are present. A person with mental illness is no more likely to harm somebody than anybody else is. The factor that most likely will predict violence between strangers is a history of violence and any criminal activity. Let's look at data collection. We need to conduct a nursing history. Provide for privacy whenever conducting interviews about family abuse. Be direct, honest, and professional. Use language the patient understands. Be understanding and attentive. Use therapeutic techniques that will demonstrate understanding. Use open-ended questions to elicit descriptive responses. Inform the patient if a referral must be made to Child or Adult Protective Services, and be sure to explain that process. Risk factors. Cultural differences can influence whether the nursing assessment data is valid, how the patient responds to the interventions, and the appropriateness of the interactions with the patient. A female partner is a vulnerable person in the majority of family violence, but a male partner can also be a vulnerable person. Vulnerable persons are at the greatest risk of violence when they try to leave the relationship. Pregnancy will tend to increase the likelihood of violence by a spouse or partner. The reason for this is unclear, but it could be related to the added responsibility or the time that will be required to care for the infant. Older adults or other adults who are vulnerable within the home can suffer abuse because they are in poor health, exhibit disruptive behavior, or are dependent on the caregiver. The potential for violence against an older adult is the highest in families where violence has already occurred. Family groups. Violence is most common within family groups, and most is aimed at family and friends rather than strangers. Family violence occurs across all economic and educational backgrounds, as well as racial and ethnic groups. Family violence can occur against children, spouses or partners, or vulnerable adult family members. Risk factors for abuse towards a child. The child is under 4 years old, and the perpetrator perceives the child as being different, such as the child is the result of an unwanted pregnancy, they are physically disabled, or they have some other trait that makes them particularly vulnerable. Let's look at types of violence. Physical violence will occur when physical pain or harm is involved. Sexual violence occurs when sexual contact takes place without consent, whether the vulnerable person is able to give consent or not. Emotional violence includes behaviors that minimize an individual's feelings of self-worth or humiliates, threatens, or intimidates a family member. Neglect. This includes a failure to provide physical care, like feeding, emotional care, such as interacting with a child, or stimulation necessary for a child to develop normally. Education, like enrolling a young child in school, and necessary health or dental care. There is also economic abuse. This is the failure to provide for the needs of a vulnerable person when adequate funds are available. Unpaid bills will result in disconnection of gas, water, or electricity. Vulnerable person characteristics. They will demonstrate low self-esteem as well as feelings of helplessness, hopelessness, powerlessness, guilt, and shame. They will attempt to protect the perpetrator and accept responsibility for the abuse. They might experience possible denial of the severity of the situation, as well as feelings of anger and terror. Perpetrator characteristics. They will use the possible use of threats and intimidation to control a vulnerable person. This will usually be an extreme disciplinarian who believes in physical punishment. They will exhibit poor impulse control and perceive the victim as bad. They will exhibit violent outbursts with poor coping skills, low self-esteem, and feelings of worthlessness. They may have a possible history of substance use disorder, and they may have difficulty assuming typical adult roles. They are very likely to have experienced family violence as a child. Age-specific assessments. For infants, for shaken baby syndrome, shaking can cause intracranial hemorrhage. Monitor for any respiratory distress, bulging fontanelles, and an increase in head circumference. Any bruising on an infant before the age of 6 months needs to be considered suspicious. Preschoolers and adolescents. Monitor for any unusual bruising, especially on the abdomen, back, and buttocks. Bruising on arms and legs in these age groups is an expected finding from playing and other physical activities. Check the mechanism of injury, which may not be congruent with the physical appearance of the injury. Numerous bruises at different stages of healing can indicate ongoing beatings. Be suspicious of bruises or welts that will resemble the shape of a belt buckle or other object. Monitor for burns. Burns covering glove or stocking areas of the hands or feet can indicate forced immersion into boiling water. Small round burns can be from lit cigarettes. Monitor for fractures with unusual features, such as forearm spiral fractures. This could be a result of twisting the extremity forcefully. The presence of multiple fractures should always be considered suspicious. Check the patient for human bite marks and monitor for any head injuries, such as altered level of consciousness, unequal or non-reactive pupils, and nausea or vomiting. For our older and vulnerable adults, we need to monitor for any bruises, lacerations, abrasions, or fractures in which the physical appearance does not match the history or mechanism of injury. Nursing care. All states have mandatory reporting laws that require nurses to report suspected child or vulnerable adult abuse. There are civil and criminal penalties for not reporting any suspicions of abuse. We need to document the subjective and objective data obtained during data collection. We need to provide basic care to treat injuries and make appropriate referrals. We need to help the patient develop a safety plan, identify behaviors and situations that can trigger violence, and provide information about safe places that they can live. We need to use crisis intervention techniques to help resolve family or community situations where violence has been devastating. Interventions for community-wide or mass casualty incidents. For early intervention, we want to make sure that these patients are physically and psychologically safe from harm. We need to provide psychological first aid. We need to reduce any stress-related manifestations by using techniques to alleviate a panic attack. We need to provide interventions to restore rest and sleep and connect the patient to social supports and information about critical resources. We need to depend on the patient's level of expertise and training. Depending on the level of expertise and training, mental health nurses will provide assessment, consultation, therapeutic communication, and support, triage, as well as psychological and physical care. Critical incident stress debriefing. This is a tertiary crisis intervention strategy that assists individuals who have experienced a traumatic event, usually involving violence, in a safe environment. This type of debriefing will involve distinct phases: introducing the purpose of the group, discussing facts about the incident, discussing first thoughts about the incident, describing personal reactions, listing altered behaviors or physical changes since the incident, reinforcing techniques on stress management and anticipatory guidance, and providing closure to the session by affirming the participants or providing referrals as needed. Debriefing can take place in a group meeting with a facilitator who will promote a safe environment where there can be expression of thoughts and feelings. The group can choose to meet on an ongoing basis or decide to disband after resolution of the crisis. Patient education. We need to help them understand their expected growth and development patterns for children. Parenting classes can be helpful. Help them develop skills to assist with problem solving. We can do this through assertiveness training. Help them find ways to manage stress in a positive way. We could do this through meditation or relaxation. And help them consider external changes that could reduce stress, like a career change or moving. Interprofessional collaboration. We need to encourage participation in support groups. Use case management to coordinate community, medical, criminal justice, and social services. Assist with patient relocation, if needed to a safe house, shelter, or a family or friend's home, or foster care. Talk with caregivers about community agencies that could provide relief, such as daycare or sitter programs.